My name is John Ireland, and I'm the president of the Papa Club. I'd like to welcome you to a panel discussion on family building, surrogacy, fostering, and adoption. Our panelists today are Dr. Guy Ringler of California Fertility Partners, Robyn Harrod of Southern California Foster Family and Adoption Agency, and David Radis of the law offices of David J. Radis. Guy is a board-certified physician in both obstetrics and gynecology and reproductive endocrinology and infertility. Robyn is the Senior Director of Programs at SCFFAA, a foster adoption agency that was one of the first to actively recruit prospective parents from the LGBT community. And David is an attorney who provides comprehensive services for private domestic adoptions for LGBT prospective parents. Welcome, panelists.
Thank you.
Hi.
Hi.
Each of our panelists is well known to our Papa Club community, and they are considered family to many of us. In fact, they have helped hundreds of our members to create our families over the nearly 2 decades that our group has existed. So I'll ask a series of questions of Dr. Ringler, Robyn, and David. I'd like each to spend a few minutes on each topic. And of course, this is a discussion. So crosstalk is permitted, and feel free to relate your experiences to that of the other panelists. Okay, so we'll just jump right into the questions. The first question I have is, for Dr. Ringler, surrogacy is our focus. What is the typical sequence and time frame?
Well, when I first meet with intended parents, I briefly review the process of egg donation with surrogacy and talk about the steps involved. And I usually begin with my intended parents of recommending to do a semen analysis. Semen analysis will give us an assessment of the sperm quantity and quality, and we can make a decision as to whether we need fresh sperm for the IVF procedure. We can use thawed frozen sperm. And if there's any sperm abnormality, it gives us time to do some intervention to try to improve the sperm quality. I then discuss different surrogacy agencies. Surrogacy agencies do the initial social recruitment and background checks for the surrogate carriers, and they coordinate the process from the beginning of the cycle until through the delivery. And generally, intended parents will meet with several different agencies and then decide which agency best fits their needs. The length of time to be matched with a gestational surrogate depends on the agency, and it can be anywhere from less than a month to 6 months. And so during that time, they will look for different egg donor candidates. They may decide to choose an egg donor candidate and begin the treatment process and freeze all the embryos to be transferred into the surrogate later. Or if their surrogate is available now, we will try to oftentimes synchronize the cycle so we can do a fresh embryo transfer into the surrogate. So getting back to the original question, I think from the first meeting with me, the first consultation to actually doing an embryo transfer can be as short as 2 months or long as 6 months, somewhere in that interval.
Now focusing a bit on fostering and potential adoption, Robyn, why don't you talk about the sequence and timeline?
Okay, sure. So all of the families that are interested in becoming foster or adoptive parents have to have a certain amount of training. So we usually start with a 3-hour orientation that kind of covers the process and what you expect. The differences between foster adopt and, the private adoption. And then if they want to move forward, we have 21 hours of training that they have to do. It's called pre-certification training. And during that time, they're learning all about foster care, about the kids in the system, what the court system is like. And they're also starting to fill out a lot of paperwork and collect documents for their family assessment and home study. After the training is over, then they start an interview process with an adoption social worker. And that usually is 3 to 4 interviews. And also during that time, they're learning a lot more about the foster care system. The social worker is learning about the families. They're also getting their life scan, their criminal clearances, then they have to do CPR and first aid. So the whole process depending on whether they do the 4-week or 8-week class series, can be 2 to 4 months after finishing their classes to have an approved home study. And a lot of that depends on how quickly they get their paperwork in and, do the things that they need to do. Once their home study is done and they're certified and ready for placement, we have families that are placed with a child the same day that they're certified, and others who, it could take 6 or 8 months and everywhere in between. And that really just depends on what the family is open to in terms of a placement. So the more they're open to in terms of age, ethnicity, sibling sets, family history, the quicker they'll get placed.
David, could you tell us now about the sequence and timeline on private adoption?
Well, what happens with private adoption is that we first set up a 3-hour consultation where I want to educate the prospective adopting parents or parent about what the process is legally. We go through mother's rights, father's rights, how they're terminated. We discuss options for terminating, whether to do an independence adoption termination via a consent, or whether to do an agency termination via relinquishment, the differences and the pros and cons on both, and the benefits that one would get from one type or the other. Then we spend a substantial period of time in discussing what to look for in a good candidate for a birth parent, what I call the reliability signals or factors that we have to deal with. Then we move on to how to talk to a prospective birth mother, because many of my prospective adopting parents have never talked to a young woman who's thinking about placing her child for adoption. So we educate them as to how to have that conversation, and then specifically how to put together materials to send to this young lady so that they are in fact competitive. And then the process usually takes anywhere from fortuitous events, which would be under 6 months, to the birth mother and baby, to as much as 2 years to the baby, unless they are specifically looking for some ingredient, if you would, that makes it more difficult. So, for instance, gender may make it harder, or specific aesthetic requirements may make it harder. And then we'll discuss the reasonableness of these requirements and whether or not they have unreasonable expectations. And then we go through the cost of adoption. And generally what happens during this process is the clients then decide they're going to retain me, and then they move forward getting their home study done if they haven't already done that, so that they get a pre-approval. And then they put their books together, the materials to send to the birth parent. They're working on that while we're looking for prospective leads. We put them in touch with prospective birth mothers during this period of time, and they follow the process. And we see whether or not this particular birth mother and this particular family can come together and work out an adoption plan. If they do, then we go forward on that. If they don't, we look for the next situation. So that's why, as I say, it could take anywhere from about 6 months to 2 years.
I want to hear from each of you about the range of costs. So we'll start with Dr. Ringler with surrogacy.
With the combination of egg donor and surrogacy, the costs are broken down into the medical costs, the egg donor costs, and the surrogacy costs. And the combination usually adds up for the intended parents of somewhere between $120,000 to $180,000, depending upon the agency, the surrogate candidate, the egg donor selected. So there's a little bit of variation. So it's a large fee, and most of our patients, plan this for several years, of course, to budget the costs. And from this one treatment cycle, so this cost would cover the one treatment cycle that we hope will generate multiple embryos to give them several attempts at a pregnancy. For example, in a typical egg donor cycle, we always hope to retrieve somewhere between 15 and 25 eggs per cycle, and those eggs will generate anywhere between 2 and 10 day 5 embryos, which are called blastocysts. And then in an embryo transfer cycle, we will transfer between 1 and 2 embryos per attempt. So most of the costs, medical costs, are in generating these embryos. And so it's always hoped that that one medical treatment cycle will provide the intended parents with multiple attempts at a pregnancy, or perhaps, multiple children in the best scenarios, where they conceive on the first embryo transfer with their first child, and they may come back a couple of years later and thaw the embryos and do a frozen embryo transfer into the gestational carrier. So that's sort of the range of the cost and what that should cover.
Cycles of sibling, the frozen embryo transfer, that's a much smaller amount than the initial 120 to 180. What's that range?
Absolutely. The medical cost for a thawed frozen embryo transfer is about $3,000 to $4,000. So significantly less than the initial medical cost, which would be closer to $20,000. Because again, the cost is into generating those embryos, the medication costs, the surgery costs, the culturing of those embryos, testing of those embryos. But once the embryos are created, the costs are significantly less. And we achieve many pregnancies, many babies from thawed frozen embryos. It used to be that there was always a preference for fresh embryos, and that the pregnancy rates, pregnancy potential with thawed frozen was much less. But today they're really equivalent, which is why today oftentimes we'll freeze embryos, great embryos, freeze them and transfer them later into the gestational surrogate, because the pregnancy rates are basically identical with fresh and thawed frozen embryo transfers. Provided, of course, the embryo quality is the same. The most important factor affecting the pregnancy rate is really the quality of that embryo being transferred.
Did you say how long a frozen embryo is viable?
They don't have an expiration date, so there's no time limit. So they can be kept for years and years. There have been live births after embryos frozen over 10 years. So it does, in the best possible scenario, give the possibility of creating your whole family from that one treatment cycle. Right. That doesn't always happen. It depends on the number of eggs being produced, the quality of those eggs and embryos from that treatment cycle.
Robyn, why don't you tell us about the range of costs with fostering?
Ultimately, there's no cost to foster or adopt through the foster care system. So there might be some upfront costs for the home study and for your live scan, but if you finalize an adoption through the foster care system, whatever you paid in is reimbursed. And when I say whatever you put in, I mean, it never really goes above $2,500 to $3,000, with our agency. So once the adoption is finalized, whatever you paid for the home study is reimbursed. And then the county also reimburses up to $400 of expenses. So your live scan expenses, any documents that you might have to have acquired, that's all reimbursed. And in addition to the adoption not costing anything, you also get a monthly stipend. So through the foster care system, you get a stipend every month. And then once the adoption is finalized, you actually get adoption assistance program monies until the child is 18. And along with that is you get Medi-Cal benefits also until the child is 18, even if they have finalized an adoption. So no cost for adoption through foster care.
Okay, and the monthly stipend that you mentioned that continues after a finalization of adoption, what is that range? What's that amount?
It ranges probably anywhere from about $500 to $900, depending on the age of the child and when they were adopted.
Per month, and that's designed to help offset costs of raising the child?
Yes.
Okay.
Yes, because in many cases, or in the past, foster parents who wanted to adopt and were unable to afford to, this was the push to get people to adopt so kids didn't languish in foster care and grow up in foster care.
Right. Okay. And can you say a word about the adoption tax credit as well? When does that kick in?
There is an adoption tax credit for everybody who adopts. You get the credit the year that the adoption finalized. And actually, it used to be that you can carry it, you can split it over a 5-year period. Um, and when you adopt through foster care, you get the credit even if you don't spend any money. So it's just by the mere fact of adopting through the system and adopting a foster child.
So it offsets with your taxable income, right?
Yes. And
Okay.
David could explain a little bit more about how it works with private adoption.
Great. Let us shift to David, and you can give us a sense of the range of costs for a private adoption.
The cost in private adoption is broken up over different levels. So first would be the home study, which usually ranges from a low of about $2,500 to about $3,500. Then there are attorney's fees that are either going to be flat rate fees or hourly fees for the adoption. There are post-placement fees to either the county or the agency you're working with once the baby's in your care. And there can be sometimes necessities of life expenses for the birth parent and or medical expenses and travel expenses. So overall, the most inexpensive form of adoption would be to do an adoption through the independent route. It's a little bit less expensive for the home study, and the post-placement study together are $4,500. Now, the total cost ranges from about a low of about $15,000 to a high of about $45,000, depending upon what kind of adoption you're going to be doing, because there are both intra and inter-state situations. The more expensive situations will involve working with a birth parent in another state. But in the nature of adoption over the last 30 years has been very much a movement towards interstate adoptions. They're really not as complicated as most people think, but they are slightly more expensive because we're dealing with a woman who is in another state, and there are aspects to the interstate compact that are expensive. The problem with adoption is the possibility that one would invest financially and not walk away with a baby. So what happens is you work with a professional who can help sort of screen the birth mother candidate to make sure that she's a reliable candidate for purposes of placing her baby. But there's nobody who has an absolute 100% record on this. There's always going to be the possibility, whether that's anywhere from 2 to 10%, that this woman is going to give birth to this child and decide she wants to parent the baby. There's absolutely nothing the adoptive parents really can do to stop that. And so there is a greater risk of loss of financial revenue and resources in the private adoption arena. So that's something that one has to be ready for. In terms of the tax credit is available for both failed adoptions and successful adoptions. Failed adoptions in the year in which it failed, successful adoption in the year in which the adoption was finalized. And it's on a sliding scale based upon income. The higher your income, the less tax credit you will get. Tax credit is just about $14,000. So the tax credit is available to people based upon their level of income. Higher income, something around, I think, $250,000, and there's no tax credit at all. But below that, you start getting a portion of the credit.
The year in which the adoption is finalized. Or it can be spread.
If it's a successful adoption, you get the credit in the year in which the adoption is finalized. If it's an independent or agency private adoption.
Great. So let's talk about risks and variables. A lot of our members and guys who are looking into becoming parents have the question, how much control can I have over this? I think each of us likes to think we can control all of the variables in any transaction, project, passion project. Creating a family is something that I think each of us wants to make sure we get it right. And so all the questions really boil down to what can go wrong. And I know that all of you on this discussion can talk about some of the variables that pop up, and just from this perspective of control, where do the risks lie, and how do you, in your practice, mitigate those and inform the prospective parents? So let's start with you, Dr. Ringler.
I think one big risk for the intended parents who are planning this process or planning to build their family is that it doesn't work. They get a negative pregnancy test. These are very thought out, planned, financed procedures, and then you get a negative pregnancy test. Well, what do you do then? It's always incredibly disappointing for everyone involved, and hopefully there'll be extra frozen embryos and we can proceed right into a frozen embryo transfer. But occasionally there's multiple failures, and so we have to go back and reevaluate. Go back and look at the sperm quality, look at the egg quality, look at this surrogate's uterus to see if we can identify any variable that we can tweak to try to improve upon. My job is to try to make each variable as perfect as possible. We want to get the best possible sperm, best quality egg provider, best quality of egg given to the laboratory. So try to make each variable as perfect as possible, but biology sometimes intervenes and has a few obstacles. So I think lack of pregnancy, even though the pregnancy rates are very high in these procedures because we're using young egg providers and putting these embryos into a proven uterine environment, the pregnancy rates transferring 2 embryos will be as high as 85%. Our live birth rate last year was 75% using egg donor and surrogacy. So the pregnancy rates are high, but there are some cases of repeat failures. Another risk is of miscarriage. Even though the egg quality is high, there is up to a 10% risk of a miscarriage, even using a young egg donor. Then we have to go back and start over again with either frozen embryo transfer or a fresh transfer. Another risk once pregnant would be preterm labor and delivery. Many of our intended parents hope to have a twin pregnancy. And if we transfer 2 embryos, the risk of a twin pregnancy is as high as 35 to 40%. But that carries that increased pregnancy risk of preterm labor and delivery. And the goal is to keep the babies in really as long as you can, as close to term. The term for a twin pregnancy would be 36 weeks. They do fine at 36 weeks. At 35 weeks, they do fine. But if they're delivered prior to that, they can spend time in intensive care unit. So preterm delivery is something we care about and always counsel patients about when we make that decision to transfer 1 or 2 embryos. What are the risks involved with that? And so I think the way we help minimize risk is by discussion at the very beginning with intended parents about what the potential risks are. We do try to make each factor as optimal as possible. And it takes really a team of professionals from the agencies, the clinics, the laboratory, to help patients along the way, to help them build the family. The end result is having that child. And fortunately, the success rates are high. But I think it's always good to talk about the risks and the possible, things that can go wrong in the cycle, because it's not always 100%. Close to that, that's our goal, but we don't always achieve that.
Robyn, could you talk about the risks and variables in fostering and adopting?
Sure. So the most important thing to remember when you're adopting through foster care or becoming a foster parent is that there are a lot of very large entities involved, bureaucracies. So we're working with the Department of Children and Family Services, we're working with Children's Court, and we have very little control as, as social workers, as intended parents, because there are all of these different players. The other important thing is these are the families whose children we're caring for. They're not choosing to place their children for adoption. It's the county or the court coming in and saying, you can't raise your child safely right now, so we're going to take them into custody, and we're going to give you an opportunity to do what you need to do to provide a safe home for your child. So there's a time period while you're fostering with the hope of adopting that the birth family is working towards getting their child back. So, we don't really like to consider it a risk, because if a family can do what they need to get their kids back, then that's great. That's where the kids should be. But in terms of families who want to adopt, for them, it's considered a risk because they have a child in their home that they're raising, and then they might have to say goodbye to. So I think that's one of the, the biggest things that we deal with when you're adopting through foster care. That being said, there are times where kids cannot go back to their families, and then the next best thing is for them to be adopted. So as a foster parent to a child, if that child is not going home, hopefully you will want to adopt that child, because we don't want them moving around, and that's going to be the best place for them. So you have first opportunity to say, absolutely, I want to raise this child and adopt them. There are also kids in the system who we're actually recruiting for, who at this point we know are not going home. And those type of situations are what we would call, or adoptive families would call lower risk, because we know up front that most likely they're going to be staying there forever.
Mitigating that risk, Robyn, is it true that you sort of you match the placement to what the prospective foster adoptive parents may prefer? So if you know they want to finalize, then you would guide them away from a placement that's probably not going to finalize.
Right. We certainly, 3 years of experience in doing this, we know how to, to assess the situation. But it's an assessment, and there is no way we can ever guarantee, whether that child is going to be staying with you permanently or not, unless it's one of those cases that I talked about where we're actively recruiting for an adoptive home. But for kids just coming into the system, for younger kids who have, whose parents have the whole, time frame to get their lives together, they might have 4 or 5 other kids in the system that they didn't reunify with, and that's something we look at in assessing, but that doesn't mean that they're not going to get it together this time. So you can't really, you can make an educated guess, but you can't guarantee, anything. And because there's so many people involved and so many bureaucracies involved, we have no control. The only thing we can control is how we take care of the kids, how we love the kids, and, and how we react to, what the situations that are happening.
David, you mentioned a term that caught my ear, reliability signals. You look for reliability signals. Is that right? Can you explain that a bit?
So we start with a phone call. From there, it's paperwork. Let's call her Nancy, because I really dislike the term birth parent. Nancy is a real live human being who chooses to deal with an unintended pregnancy in a very emotional way by placing that child. And she wants to look for certain things in a family. Well, the family that wants to adopt has to look for certain things in Nancy. And one of those things is that she will return phone calls, and that she will go to the doctor, and that she will, if we request it, which in my practice we do 100% of the time, get a drug, alcohol, HIV, hepatitis, hep C, STDs, and I even request a Huntington's disease test. I want her to go through certain medical steps that my clients are asked to pay for. And if she does that, she's starting to establish that she really is goal-oriented towards placing this unintended pregnancy with my prospective clients. And then from there, the next step would be potentially meeting with either an adoption service provider, which is a social worker in the independent adoption process, or a caseworker with the agency, if it's an agency process, and actually going through additional steps that the agency or the adoption service provider requires, while at the same time staying in touch with the adopting parents, usually anywhere from 1 to 3 or more times a week. Now with texting, it's probably more than that. So from a reliability factor, we going back to your original topic, that of control, it shifts the control to the adopting parents to be able to assess whether or not, for their own level of comfort, they feel that Nancy is demonstrating the control and demonstrating the reliability that they're comfortable with before they commit beyond today. So you don't commit tomorrow until we get to tomorrow, and we don't look at yesterday to determine that we should go forward to tomorrow. If today is not what we want, then we pass on the situation. And I leave that up to my client completely. I never really argue with clients other than to explain to them, well, all right, if you pass on Nancy, that's fine, that's your decision. I always say one man's candy is another man's poison. And you're welcome to think about this as not being sweet enough for you or too sweet for you. And we'll pass that birth mother to another family. Or if I agree with them, I will say, fine, I completely agree with you, and I will not pass Nancy to any of my other clients. So my families in adoption have complete control over this process. Plus, when you get into the economics, they're in complete control. They decide whether or not they're going to be willing to cover whatever the expenses are required for that particular scenario. And unlike Robyn, where Robyn's focus many times is for reunification, clearly the private adoption is not for reunification. So we're looking for the ability of Nancy to be able to terminate her rights, get on with the rest of her life, because no matter what lots of people think about it, and Robyn, I know, knows me, so she knows that I'm not heartless. Many of the professionals in this field are, really caring individuals. We want Nancy to get on with the rest of her life and not worry about Nancy hanging herself in the closet 6 months later because she regrets her decision. So we want to get her counseling either through the adoption service provider or private counseling, or work with an agency. And by doing that, the client is getting more control over the process because, again, they're beginning to feel that Nancy understands the process and therefore becomes a better risk.
One of the reasons why we at Pop Love Club love all three of you is because you guys communicate very well with us as prospective parents. And I think that's the key around this risk conversation. And control or lack of control, variables that will pop up is the communication, that we can fully understand what we're engaging in, what is entailed in the process, and that you're there as the professionals to help guide us through that. So on behalf of a lot of our parents, I'd like to thank you for that guidance along the way. In closing, I'm gonna open up everybody's mic and see if you have any last sort of guidance or words of wisdom to a prospective parent that is seeking out resources through Pop Love Club.
Well, I don't mind jumping in on that one. I always recommend the Pop Love Club, and I'm amazed at how many gentlemen call me and are unaware of it until I point it out to them. And then I usually get thank yous later because they didn't realize this resource existed. And just not just a resource, but you guys are like an encyclopedia now on this area. You have everything available to you.
I have to agree. I think it's amazing that intended parents have these resources available of how they want to build their family, either through, you know, fostering or private adoption, you know, using an egg donor and surrogacy. And it's great, John, that Pop Club offers these resources. I was on a trip to China in January, and we gave seminars on gay and lesbian family building in all the major cities. And it was interesting because we didn't know who would show up, if anyone would show up, if we would get shut down. And we had 200 people in Shanghai came up. They were just hungry for information. And we mentioned the Potluck Club because we wanted to build this community of, you know, fellow intended parents to help each other through the process. And that's what the Potluck Club does, which is pretty great.
Yeah, I mean, I just echo that in terms of either families coming to us because they heard about us through Potluck, or if they hadn't, referring them there and them just being very thankful to have, you know, a place and support. Because no matter what process you're going through, you know, to form your family, the more support you have, you know, the better it's going to be for you. And nobody knows what you're going through unless they've been through it also. At least in this world. So having you there is a great resource.
And if I might add, every time I've been to one of your events, I really get off on how it's not just for the dads, but it's for the kids. And how much the kids get out of it. They're not the only child being raised by a single father or by two dads. And it's perfect for the children.
Well, we are happy that we've all found each other to share our resources. And I just would like to close by thanking each of you for the great information you provided. Today's webinar is a bit of a teaser for this weekend's in-person panel discussion, where our members will come and be able to speak with you directly. We do this each year. We address a bunch of different topics, and this is a very important one to all of our members. So you've been wonderful resources to our community for years. Thank you for taking the time today. Again, Dr. Guy Ringler of California Fertility Partners, Robyn Harrod of Southern California Foster Family and Adoption Agency, and David Radis of the Law Offices of David J. Radis. On behalf of all of our members and the board of directors of the Pop-Up Club, thank you.